without further ado, we're going to start. As you guys know, this program's funded by Pfizer. We're going to start with Dr. Ari Grinspan, who's going to talk to us about C. diff in IBD. A hot topic.
That is right. Okay. Hello, everybody. And for those tuning in, I'm Ari. I am the self-appointed shit king of Mount Sinai. Can I say that? I can say that. Okay. We are...
Unedited.
This is my first time on television. All right, so let's dive into it. C. diff infection in inflammatory bowel disease. We see it all too often. It's important to note just some baseline numbers. If you have IBD, you are 5 times more likely than anyone else to have an infection with C. diff. But you're 8 to 10 times more likely to be colonized with C. diff. And we'll talk about that difference because that is a very, very important difference. It can be very confusing clinically. It can be challenging to identify if your patient with IBD has a C. diff infection or not. Patients with IBD, these are usually, they get C. diff from being in the community. They don't have to be in the hospital like they were 20 years ago, where you think about the old person with this kind of infection and then they get C. diff from a hospitalized acquired infection. This is community onset. They are typically younger. The problem with C. diff is that it can resemble their IBD flare. So just clinically, it can be challenging to understand what is causing their infection. The other thing is the classic pseudomembranous colitis. We rarely see that in patients with IBD, maybe 10% of the time, give or take. The risk factors, and this is based off of retrospective studies, if the patients are on steroids, if they're on anti-TNF. I don't buy that, but that's published out there. If they've been hospitalized recently, and the patients who come see us the most are the ones that are more likely to have develop a C. diff infection. This comes straight from our guidelines, the GI guidelines. All patients with IBD hospitalized with disease flare should undergo C. diff testing. So at Mount Sinai, we see a ton of C. diff tests being sent off, and it's our job to analyze those and interpret those correctly to make sure that we're doing the right thing for our patients. All ambulatory patients who develop diarrhea in the setting of quiescent disease or presence of risk factors should be tested for C. diff. This is in our GI guidelines. All right, so how do you test? Well, you order in Epic, C. diff. And at Mount Sinai, some of you will get this individual information, and some of us will get an interpretation of these results. If you send your test to a community lab like LabCorp or Quest or whatever it may be, you will get the individual components here. So the GDH over here, this is found on all C. diff bacteria. It is remarkably sensitive for the presence of the bacteria itself, but that's all that it does. It just says you C. diff is there. It does not tell you anything else. It doesn't tell you whether your patient is having a C. diff infection. It just says it's there. Okay. The best test is this one, the toxin enzyme immunoassay, which is looking specifically for the toxin that causes the entity that we call a C. diff infection. The presence of C. diff alone is meaningless. We don't care if the bacteria is there. We only care if the toxin is being made. And this is the only test that can actually tell you whether toxin is present at the time that you submit that stool sample. A lot of labs and a lot of hospitals will only run a PCR test, which is the most sensitive test for the presence of toxigenic C. diff, but it is a DNA test. All it's telling you is that the gene that encodes for the toxin is present in your sample. It doesn't tell you whether the toxin is actually being transcribed or not. And that is a big issue, especially, I just told you that in our patients with IBD, a lot of them can be colonized. So C. diff can be present. And so the toxin PCR might be positive. The GDH could be positive, but if it's not being transcribed, if it's just an innocent bystander, the toxin enzyme immunoassay will be negative. This can be very challenging to figure out. No single test is perfect and can singly diagnose a C. diff infection. It's a combination of what you clinically think is happening with the patient and, yes, using these tests, but you have to make that interpretation. Okay, what do you do when your patient does have a C. diff infection and they have IBD? Do not hold their immunosuppressive agents. Continue them on whatever they're doing. You can continue steroids, treat the underlying IBD as you are treating the C. diff infection. So whether you're using vancomycin or you're using fidaxomicin, that's sort of dealer's choice. My preference is fidaxomicin just because it is more narrow spectrum, and it's not like dropping a bomb to destroy everything in the microbiome. But continue to use your immunomodulators, your steroids, your anti-TNFs, because none of these are associated with adverse outcomes associated with C. diff. So your patient's IBD.
I just wanted to emphasize, a lot of times patients come in with a UC flare and people say, don't start steroids till we get infection studies back. Can you just address that?
Yes, so if your patient comes in an IBD flare, start steroids. And then when the C. diff comes back, okay, it's positive, treat them with vancomycin or fidaxomicin, whatever you have in the hospital setting. But don't hold off on steroids because you're waiting for C. diff. Again, steroids will not cause a bad outcome for patients who are having a C. diff infection.
Yeah, I was just gonna ask, I think you just answered, because the teaching has been, of all the things that you want to get the patient off, it's steroids. And Monty and your friend Larry Brand had across the board all diseases. Using steroids was a terrible outcome if steroids was, as an independent variable. Now, I might be wrong, but I would think in UC, if steroids aren't working anyway, you start the patient anti-TNF or cyclo or whatever you want. It's an excuse to get the patient off steroids because it might make the C. diff worse. Or you're saying there's really, steroids don't influence outcomes?
Steroids have they do not influence adverse outcomes associated with C. diff in any way, shape, or form. It's been looked at multiple times now.
No, C. diff in UC.
C. diff in UC. C. diff, if you have inflammatory bowel disease and you have a C. diff infection, you're on steroids, there's no worse outcomes for those who are on steroids or not from a C. diff perspective. We're talking about fulminant C. diff or colectomy that was driven by the C. diff infection. The UC is a whole separate entity, but just from a C. diff perspective, don't be afraid of blasting your patients with immunomodulators, anti-TNFs, JAK inhibitors, steroids. Okay, so, but then the real question is, why is your patient in the hospital? Is it from the C. diff, or is it the IBD that caused their symptoms? And this is very challenging. So colonoscopy can be helpful in these patients. Again, if it's only a C. diff infection and their UC is quiescent, C. diff doesn't ulcerate. C. diff doesn't invade. It's a toxin-mediated colitis. What we classically see is a pseudomembranes. The problem here is that C. diff can activate the underlying colitis, and that's usually what we're seeing. So we have to treat both of these entities. So what do we do? And this is from our guidelines. You give 3 days of vancomycin, in addition to if they're on steroids or whatever you're doing. And at the end of the 3 days, if your patient is not better, then hit them with whatever agent you want to do to treat the underlying IBD and continue them on the vancomycin. We have data from here, unpublished, but looking at patients with IBD, with UC specifically, admitted with a diagnosis of C. diff. Now, at Mount Sinai, we're not given the information about what made that C. diff result positive. So it could have been just PCR, or it could have been toxin enzyme amino acid. We don't know. You just get an interpretation. Your IBD patient has C. diff. When we broke it down, we went to the micro lab and we looked at it. 75% of patients with UC diagnosed with C. diff were toxin negative and PCR positive. So they were colonized with C. diff. And what happened is that we delayed the appropriate management compared to those who had a true positive. So the true, yes, Allie, go ahead.
I know you've talked to the micro lab, but instead of us calling every time, is there any way that we can have them change this reporting?
Yeah, so at the west side, Morningside and West, they give you all of the information, and they're working on transitioning that here as well. We're not quite there yet. But again, 75% of our patients who have UC and get admitted with a C. diff were just colonized.
So how do we know?
You call me.
No, but if we don't know, if we don't have the result.
So you don't. At this moment in time, Sinai does not give you that information. It's wild.
What do they give you?
They give you an interpretation. So this is what they give you. They give you the GDH, and they do the GDH and the toxin enzyme first. If they're concordant, meaning they're both positive or both negative, you get that result. The interpretation is positive, the interpretation is negative. If it's discordant, which is always GDH positive, but toxin enzyme immunoassay negative, they run the PCR as the tiebreaker. And then this will tell you whether you get an interpretation of positive or an interpretation of negative.
And whose idea was that algorithm?
New England Journal of Medicine 2015. This was their idea of a better way to diagnose C. diff, but they did it backwards. Yeah, they did this backwards. It should be, what they should be doing is they run only the toxin enzyme immunoassay first. And then, the PCR should be run first. Sorry, PCR is first. If it's positive, you confirm it with the toxin. If it's PCR is negative, you're done. There's no C. diff. But they don't do that here. All right. Again, this is part of our guidelines.
I mean, just a point. Why patients with IBD have less pseudomembran?
We don't know why the patients, and it's probably because they don't have C. diff. It's probably their colitis. That's probably what it is.
So also remember that a lot of patients with active UC, not even the hospitalized type, have something that looks very much like pseudomembranes.
You can get this exudate thing, and is that pseudomembranes, and it's a little bit unclear. But again,
So we shouldn't rely upon that.
no, you cannot rely on that alone. Exactly. So this comes from our guidelines. This is now a couple years old now, but the bottom line is your patient with IBD has a positive C. diff test. Treat them with vancomycin, and if they are not better in 3 to 4 days, escalate their immunosuppression, boost them with Remicade, switch them to a JAK, whatever you're going to do. That is okay to do. We have good data about how long should you extend the vancomycin for. Well, not good. It's one cohort, but the longer your patient is on vancomycin, the less likely they are to have a recurrent episode. So this changed the ACG guidelines. So for a standard episode of C. diff, you should be treated with 10 days of vancomycin. But if you have IBD, they recommend a minimum of 14 days. And this is really based off of David Rubin's study that showed that if you're on a longer duration of vancomycin, which was 21 to 42 days, then you had a significantly less chance of having recurrent C. diff compared to those who got a standard 10
You just
days.
said 14. Why don't you say 21 to 42?
Because they hedged. This is one data set, one cohort that is trying to change guidelines, and it's expert opinion at 14. I'll tell you what I do.
Not randomized, I'm sure.
No, not at all. So I'll tell you what I do.
Okay, because, yeah.
Patient comes in a hospital and they have a UC flare and they get C. diff, and I'm going to change their therapy. I continue vancomycin until they get whatever the next drug is going to be. I don't want them to get a C. diff flare or a recurrence while I'm in the middle of changing their therapy. It's going to muck everything up, and then I don't know what's
Do you
going
do a
on.
tapering vanco course?
If they're going to be longer than 3 to 4 weeks, there's no real need to do a taper.
Okay.
But I always bring them down to BID for a week and then daily for a week until I can get them onto their drug.
Well, that would be a tapering course.
Yeah, it's a taper, but it's a made-up taper.
But I make it a taper too. Okay, so good.
All right, what's the yield on patients who come in? I assume everyone comes in with acute severe UC gets a baseline C. diff. What's the yield on repeating it sometime during their hospitalization?
0. There's no need. Because if we're going to be on antibiotics, if they're going to be on Vanco, the test is going to be negative.
No. They're not on Vanco. They come in C. diff negative. Is there a point, is there any significant degree of incidence in hospital and patients on acute severe UC. in that first
Epidemiology
seven-
will not allow you to send a test if a patient has a negative C. diff result for 7 to 14 days afterwards. So unless your patient suddenly like decompensates, that's a different sort of
Well,
situation.
they're all the ones who are, we want to know are the ones who are decompensating, right? They're getting better, we're not.
But usually they won't let you do it for 7 to 14 days after their negative result.
Is there data somewhere of people acquiring C. diff in the hospital off antibiotics? With
Yeah.
Acute severe UC?
We don't have that data, but hospital-acquired C. diff, it's a big deal, and
Well, shouldn't we be
have
able
that
to
data.
check for it?
In the right clinical setting, you can get it done. You have to get ID to approve it, but that's not standard.
We're gonna keep going just because
Yeah,
we have to
yeah.
get to the
Okay,
cases.
good.
Bezlotuximab, is there a role for this monoclonal antibody against C. diff in our IBD patients? This is teeny tiny bits of data that suggest maybe. We just ran a trial here comparing patients to get FMT. Instead of the IBD, they got recurrent C. diff. Everyone gets an FMT, and then half those patients either got Bezlo or placebo, and there was no difference in that cohort. So is there a role for Bezlo? We don't really know what to make of it yet. There absolutely is a role for fecal transplant. We've shown that an FMT in the setting of IBD works just as well in the non-IBD patients. 90% efficacy at preventing another episode of C. diff. Don't be afraid that an FMT is going to make things worse. There was 1 patient out of 50 who had a de novo IBD flare about 2 months after the fecal transplant, probably because they weren't treated appropriately for their IBD. Anyways, there are these new drugs that are out there. Rebiota, which is an enema product, full spectrum. Voust, which is a fractionated FMT product, meaning they took some shit, they put some alcohol on it, stirred it up, and they got these sporulated bacteria. That is a fractionated specimen. And then Vedanta has this VE303 product, which is a true non-fecal sample. It's 8 species from cell banks. And this is a defined cocktail. The bottom line is that none of these have been looked at in IBD. All IBD patients were excluded from these trials. We don't know if they're going to be effective or not. But I'll tell you that I've been using Voust a couple times in IBD patients, and it works equally as well.
Can we get a hold of the placebo though?
Huh?
That placebo looks great.
Yeah, the placebo looks really good, doesn't it? Right? I'm telling you, that's some good stuff right there. Okay. In summary, any patients that change in symptoms, specifically diarrhea, you got to check C. diff. Toxin enzyme immunoassay is the best. At diagnosis, do not hold immunosuppressives. It's okay to blast your patients. They will not have an adverse outcome from the C. diff. Consider a colonoscopy just to see what's going on. Have a short leash while you start antibiotics. And if they're not better in 3 to 4 days, blast them with IBD-directed therapy. FMT is safe and effective. And these other drugs, we don't really know where they are, but we'll have more data in the coming year.
I'm not gonna do questions right now because we gotta get to the cases. Ari, that was incredible. Thank you so much.